Commission on Race and Access to Opportunity. Our October meeting will come to order. I appreciate all of you being here today to join us in the conversation as we continue moving forward on discussions around race and access to opportunity. I will encourage all of you, please silence your cell phones, if you would, as I'm going to try to do mine right here in the same moment, and we will ask our staff to please call the roll.
Senator Berg.
Present.
Senator Neal. Senator Westerfield.
Here.
Representative Brown. Representative Kulkarni. Representative Timoney. Mr. Davis. Ms. Drake. Mr. Jones. Dr. Oleka.
Here.
Mr. Roberts. Chairman Gibbons.
Present in the room.
Chair Havard.
Present.
First order of business is approval of our September the 28th meeting minutes. I need a motion to accept the minutes. Have a motion, a second.
Second.
All in favor say aye. Aye. Any opposed? We have ayes that are unanimous. So record will reflect approval of those meeting minutes. Let the record reflect also the attendance of our esteemed colleague, Senator Neal. Senator, we're glad to have you here with us. So today's topic is going to be health and health outcomes. We do have a robust agenda of 4 presenters, and we'll hear from several representatives about issues related to the topic of health and health outcomes. We also will be hearing from Senator Westerfield on an important piece of legislation directly related to the mission of this commission. And so we will try productively but aggressively to stay on a 30-minute schedule for 30 minutes or less for each of these presenters. And so with that, we are proud to welcome to the table Norton Healthcare's Institute for Health Equity. Please come on to the table, introduce yourself for the record, and you may begin. That microphone button always looks green, but it needs to be a brilliant, bright green, glaring at you sort of green. Push the button and it will become a robust green.
All right.
That's it. We're going to give you about 30 minutes. Please leave some time for Q&A. 15. Our staff says 15, and if our staff says 15, that means 15.
I'll try to stick to that. So for the record, I am Kelly McCants, representing Norton Healthcare. I am the executive director of the Institute for Health Equity, as well as the executive director for the Advanced Heart Failure Program. So very excited to be here. Thank you for Mr. Roberts, Irwin over there, and Senator Neal for just giving me the opportunity to not only talk about what Norton Healthcare is doing, but talk about healthcare disparities and what it looks like in Louisville. So with that, I'll get started. And this is my first disclaimer slide. And I use this as a disclaimer because the language is a little bit straightforward, but this is the language of Dr. King from the 1960s. But I think this language sets the stage for what we need to address. It says, it is argued that the Negro is criminal. You see, he has the highest crime rate in any city. And these arguments go on and on. But those who use these arguments never say that there are lagging standards in the Negro community. They never go on to say that the criminal responses are environmental and not racial. Poverty, ignorance, economic deprivation, and social isolation is what we're really dealing with. And so Louisville is unique, and you've heard this before, but when we start talking about healthcare disparities and life expectancy, you can't do that without speaking about redlining. And so Louisville, unfortunately, is one of the most segregated cities in the United States. From a geographic standpoint, 86% of all African Americans live west of 9th Street, and your life expectancy drops by 12 years. And this historical policy of zoning reform associated with redlining was historical in creating this geographic separation. This language is also a little bit rough, but again, it sets the stage. Redlining was introduced in the 1910s. So this is, for the students in the room, this is not a policy specific to Louisville. This is a policy that came out of Baltimore in the 1910s. You can read the language very quickly, but I'll move beyond that. And why is this important? We know that housing is tied to wealth and wealth is tied to health. And so it's almost impossible to speak about health and outcomes without addressing housing and some of the challenges that the redlining process or policies created. And so when you start thinking about zoning decisions, it's appropriate for this committee. These are things that we all know, but let's keep it front and center as we think about opportunities to move the needle. These zoning decisions permitted a lot of what we see in terms of liquor stores, nightclubs, and certain houses in these areas, which you don't see when you cross to the east side of 9th Street in Louisville. When we think about other cities, again, this is not unique to Louisville. There was a certain city architect and planner by the name of Harlan Bartholomew that was instrumental in doing this in almost every major city in the Southeast. And so that's why Memphis looks like Louisville. That's why Nashville, that's why Savannah, and some of the other areas that are heavily populated by African Americans. When I say heavily populated, 20% or more, that's why the disparities look the same. And so I wanted to take a point to set the stage for what we're dealing with. And this is a picture of Mr. Bartholomew. So in Louisville is called a sister city to New Orleans for a reason. This is a redlining map on the left of the city of Louisville, and on the right is New Orleans. And these are mirror images of each other. One has the Ohio River that creates the crest, and the other has the Mississippi. The fact still remains, in both Louisville and New Orleans, 86% of all African Americans live within 2 to 3 miles of downtown. And so this was also a city designed by that same city planner. The 1930s was an interesting period where redlining was at its peak, but it was also the period where the President Roosevelt, supplied over $3 billion in support for over 1 million mortgages. Remember, the point is that healthcare and wealth is tied to housing. Well, 40% of the U.S. population was able to benefit from this support. Less than 1% of African Americans benefited from this particular support. Didn't matter if you were a returning GI, even though you had the opportunity to benefit from the GI Bill, the policies and the administration of these loans was done at a local level. And so if you happen to live in an area that was high in redlining or banking opportunities were not available, even though you were a veteran, you still didn't get the benefit. And we're in a room full of policymakers, policies that were put in place. We're still feeling the effect from redlining almost 100 years later. And so while it was a successful policy, on one hand, it is still the number one policy for creating healthcare disparities across the United States. Let's talk a little bit about green space and tree canopy, because you can't speak about it without understanding redlining. When you look at these communities, there's no green space. And why is this important? So when you cross over 9th Street in Louisville, less than 1% of the land is green space. When we were kids, we understood that photosynthesis was important. And so if you look at this slide, pay attention to what's in the middle. In that population where 86% of all African Americans live, there's an inverse relationship between vegetation and air pollution. And you see this rampant throughout a lot of the cities in the United States. Green space, less than 1% in the California neighborhood. Commercial and industry, 50%. You don't see that when you move eastward. So you lose about 12 years of life in Louisville if you drive 4 miles. So we may want to be careful which way we drive, because if you drive toward the west end, and you're in the communities or the neighborhoods of Russell, California, and Portland, you just lost 12 years of life by moving westward. There's other challenges, and the challenges are pretty clear. And so this is a excerpt from our health equity report. And what you see here, these are the 9 neighborhoods of Louisville, and they have the same challenges. And if you look at that heat map, the challenges are education, income, transportation, crime. Anything that you can measure is worse in these communities. We talk about redlining and home ownership, 70% of renters. The most alarming statistic for me is that 60% of the folks in these communities are females as the head of the household. And so when you talk about women's health, which I know we will in just a little bit, if you have a female as the head of the household in this disparate environment who has to work and hold 2 jobs, talking about healthcare becomes a little bit challenging. And so just to make the point, I don't like to pick on Louisville. We want to support Louisville. But what we see is prominent across the United States. So 65% of all African Americans live in the states that are highlighted here to this point in time. And these are also the states that have the highest disparities in access in healthcare. Let's look at Savannah, for example. We all like to visit Savannah, good food and a lot to do in Savannah, but Savannah looks like Louisville in that these 2 zip codes are where 86% of where all African Americans live. And I'm using this as a comparison because this is also where you have the highest poverty level, you have the highest food insecurities, and the greatest distance to grocery stores. I'm a cardiologist. This is also the place where you have the highest hypertension, heart disease, and diabetes. And so when we're thinking about life expectancy, again, in Chatham County, which is Savannah, in those zip codes, you again lost 12 years of life. And so while these cities may be over 500 miles apart, the healthcare disparities look the same. And I'm moving quickly in respect to time, but also the highest utilization of food stamps are in those districts and the lower homeowner occupancy. And I'm showing you Savannah again here for a comparison. Here's the unique part. This slide is a little bit busy. This is not Louisville's health equity report. This is HRSA's equity report. And you see that there's a direct correlation between cardiovascular disease, workforce, and unemployment level. And you look at which population is leading. This is not a category that you want to be leading. But as I go to the next slide, those bar graphs you can almost superimpose. And that slide looks at homicide. And so now there's a correlation between homicide, workforce, cardiovascular disease, and unemployment level. And this data is from HRSA. So you can Google this data when we're done or keep these slides. But it's very impressive to see that correlation there. So I want to spend the next few minutes, if I have them, talking about the importance of social capital. We started this conversation with a quote from Dr. King talking about social isolation. The degree of social trust, the development of social networks, and the willingness of a population to provide mutual aid and reciprocity is important. You can't do that in those zip codes if you don't have the following. If you don't have individual upward empowerment, if you don't have that social capital, and if you're experiencing environmental behaviors that end in stress, discrimination, substance use, and nutritional issues. And you see that racial residential segregation on the left side is tied directly to health outcomes on the right side. When we start looking at punishing and toxic neighborhood environments as it relates to intergenerational social mobility, when you look at this particular graph here, there's a bimodal distribution. So at the top, you have a majority white population. At the bottom, you have a majority black population. Completely separate when we start thinking about social mobility for both black and white children. This one's a little bit busy, but let me call your attention to the bottom half. When we start thinking about environmental racism and we start tying in healthcare disparities and we tie into everything that a community can suffer from, there is a standardized coefficient. And if you look at the p-values for lead exposure, violent crime, incarceration rate, and of course, infant mortality, it all ties together. And so these communities almost have a double, triple, or quadruple whammy. All right, so let's get to Norton Healthcare. So why am I here and why is Norton Healthcare leading in health equity? We understand that as a large healthcare system and economic engine that we need to use our resources to bring about change, particularly in Louisville. If you look at anybody's community needs assessment, any non-for-profit organization as a part of the Affordable Care Act has to do every 3 years a community needs assessment. I'll save you some time from reading everybody's. They all look the same. Access to care is number one. And so for this committee, no pun intended, but access is crucial in everything that these communities suffer. But if you don't have hospitals, if you don't have clinics in these areas, you can forget about making change because you didn't give them access. So access to care, access to primary care is important, transportation, but more importantly, lack of specialty providers. We're always talking about primary care, but no cardiologists, no endocrinologists. You can forget about seeing an expert in maternal fetal medicine because they're just not there in that community. So I'll move quickly. The data also suggests that we should build a hospital in Louisville's West End. If you look at the demographics here, in terms of utilization of resources, I tie your attention to the Western demographic, higher inpatient admissions, higher ER visits, higher outpatient surgeries. So while it is the mission, vision, and values of Norton Healthcare, in terms of doing it for that perspective, the data suggests that you should do it also. Your encounter for healthcare should not be in the emergency room. It should actually be in your primary care office. These are the disease states that always rank at the top of the list in these communities: cancer, heart disease, and stroke, as well as hypertension and heart failure. But mental health is huge. And to think that any one system has an answer to mental health is a bit of a challenge. For mental health, we cannot operate in silos, but the mental health burden in these communities is extremely high. Just to zoom in a little bit, this is that bump that we saw on the Ohio. Top neighborhood is our Portland neighborhood, middle is Russell, and bottom is California. Red dots are African Americans, blue dots are non-African Americans. So at first I said this was about poverty and geographic segregation, but in certain communities, certain populations still coalesce together. So go back to that social network that we're talking about. So everybody here has an income of about $22,000, but still like populations tend to cluster, which really puts both populations at a social disadvantage. So time for change is now. We started out with the Institute for Health Equity, led by myself, and the vision of our CEO, Russ Cox, and our leadership team said, we're going to improve health equity. We need to have a site-based investment in the West End. And so this is a 40,000 square foot building. We have 2, soon to be 3 units in this building. But our job is to be in the community where the healthcare disparities are instead of trying to affect it from outside the community. In that building, I won't spend a lot of time here, but everything that affects the social determinant of health cycle happens in that building, from banking opportunities to AMPT, which is a business incubator, to Head Start programs, all situated in that building. And it is the flagship building for health equity as it relates to Norton Healthcare. Not just that building, Norton has made some significant strides well before the racial injustice that has happened in Louisville. Our location at 18th and Broadway, the Sports and Learning Complex, our relationship with the African American churches. And so we have supported medical programming in both churches, Bates, and St. Stephen's to the tune of $1.4 million around medical programming. We will have a student health clinic at Simmons that will open in the spring. Just a quote, and I'm almost done. Health equity is not about treating all patients the same. Okay? We lost the ability for sameness back in King's Day. Now it's about treating people different because people have different challenges that get in the way of them reaching their desired outcome. So we don't want to walk away thinking that equity means the same. Equity actually means treating people differently. Every organization is going to have a division of equity, inclusion, and belonging, and I'm not trying to take away from that. Equity, inclusion, and belonging and diversity looks within the organization. The Institute for Health Equity looks outside the organization and how that organization interacts with the community. Almost done. So we're building the first hospital in 150 years. I started this presentation talking about 1930s and FDR and redlining and the homeowner loan corporation. About the same time, the only hospital in the West End closed in the 1930s as well. And so it shouldn't take 150 years for anyone to have access to health care, but Norton wants to be leaders in this area. And so we're building a campus in conjunction with Goodwill Industries of Kentucky on 28th and Broadway. This slide says a $70 million investment. Let's just say we blew by that a little bit, pretty close to $100 million now. But this is a fully functioning hospital, 20 inpatient beds, ER beds, adult pediatric primary care, and what I'm most excited about is specialty care. And just in terms of wrapping up, we want to set the blueprint for how large healthcare organizations ought to interact with the community regarding healthcare disparities. So I'll pause for questions now. Thank you.
Nice work. You did that in about, I'm told, 46 slides in about 20 minutes.
Sorry I went over a little bit.
Well done, really well done. And I'm encouraging members to gather questions, run through our staff. Let me see some names appear on the list. I'll be glad to call on you. I'd like to ask you if you would pull your presentation back up, though, and back up to a slide I'd like for you to spend a little more time on because this was significant. This is the slide with your chart, the social capital chart. It's maybe halfway through your presentation. That one, yes. Talk to me again about what we're seeing here.
So this is interesting, and the data is represented from the bottom here. And a lot of times we talk about economic investment, but you can imagine, and I'll give you my interpretation, then we'll walk through some of this. You can imagine if you're on the east side of Kentucky, or let's just look at the folks here in this room. Your conversations are much different than the conversations that are happening at the community level in West Louisville. You're hopefully talking about stock options. You're talking about kids and going to college. You're talking about different relationships. You're talking about vacations that you want to go on. Those conversations are not happening at the same level in those communities. It's more about economic opportunity, which sometimes translates into negative behavior. And so a lot of times we don't spend a lot of time addressing the social construct that exists in these communities, but they need to see a Senator Neal. They need to see a Dr. McCants. They need to see a Erin Roberts, and they need to bring their conversation. I'm talking to the kids behind me now. They need to bring their conversations up to that level and not down to the level that reinforces negative behavior.
That's powerful. Dr. Oleka.
Thank you. I want to continue on this topic. Social capital is what my dissertation was in, so this is something I understand really well. Let me ask this question, and it's going to sound like a controversial one. It's not meant to be. It's meant to be a straightforward one, I think. Where do you think these negative reinforcements come from? As in, if I'm a black student. I go to Jefferson County Public Schools. I'm in 9th grade. You can pick any high school. Where am I most likely to hear these negative reinforcements? This few part questions. That's the first one. Where am I most likely to hear positive reinforcement? And then the third one, because obviously a big part of social capital is what is the institutional response? Norton Healthcare is an institution, I think, is trying to do the right thing. What should be the institutional response from the school district and from the city? So you heard them, but I'll repeat them for everybody else. If I'm a 9th grade black student from West Louisville and I am in Jefferson County Public Schools, where is the negative reinforcement coming from about what my opportunities are? Where's the positive reinforcement coming from? What is the responsibility of the school district and of the city government to do better for me?
Powerful. First, your negative reinforcement is coming from your peers, right? You know, I'll go back to when I was a kid. I did some things that probably I shouldn't have, but guess who was next to me doing those same things? My peers. And it wasn't, and I'm answering question number 2, the influence from outside my community gave me that positive direction. Most of my mentors were not African American, right? These were people that were white females who happened to be teachers. These were Indian professors that saw something in me that thought I should go forward. And so most of the mentorship was from outside. And I'm not denigrating what's inside the community, but I made a point here to say that 60% of the population are women in that community. And so the male leadership is not there. And when the male leadership is there, it's coming from a peer level. And so that answers question number 1 and 2. Large institutions have to understand this first, right? And so one of the things that I think my opinion adds value as it relates to Norton Healthcare is to bring awareness and say, look, as we're designing this hospital, you got to understand that people are going to be loud. People are going to be on their cell phones. There's going to be TikToking going on. There's going to be a lot, but I don't need security to address it in the way they normally would. All right. I need you to allow for people to be people until it gets beyond a certain level, because the social interaction is different and we need to account for that. And so I hope that answers your question. But understanding the social context that you provide, whatever service it is you provide, is powerful.
Representative Cole Carney.
Thank you, Chairman, and thank you for this over here comprehensive, very informative presentation, Dr. McCants. I have a couple of questions pertaining to the hospital. Why, in 150 years, wasn't there one built? Because I'm, anecdotally or otherwise, I'm sure the communities that have lived in these areas are aware of the health disparities and the health outcomes that their families are facing. And why did you all decide to build now? And then my second question, if you want to just answer that one, and then I have a follow-up, Chairman.
So that's a powerful question. Why? And the answer to that is shame on us. We should have a long time ago, and that responsibility doesn't just fall on Norton Healthcare. There are 3 other healthcare providers for the city of Louisville, but Norton Healthcare touches 1 in 2 African Americans in the city of Louisville. And with that comes a lot of accountability. And our CEO and our leadership team, they understand that. And initially, our investment was supposed to be $20 million over a 2-year period. Now we're up to $120 million over that same period. And as we gathered more research, we understood that our lift needed to be bigger. So I can't say why it wasn't done before now. I can just say that we're intentional about doing it now.
Thank you. And quick follow up. My second question has to do with the care that will be provided
Sure.
at this facility. In a couple of slides, I think you had the words mental health and substance use in bold. I don't see that in the list that's provided now. Is that something that you're anticipating? Mainly because back in one of these other slides where you had, 70% of these areas are renter, 60% are women, female head of households. There's an 87% AA population. Is that
African Americans.
Okay.
Yeah, African Americans.
African Americans? There's a utility disconnection rate. One banker for every 1,200 people. So my question is, how are you going to get people the access to the care? Right. I have Norton, like my chart. Everything is online. Appointments are made online. So if you have no internet, that kind of thing, how are you going to access this care? And then the other part was, were you planning on adding mental health and substance use?
Sure. So we're very cautious in how we approach mental health. And the reason why is there are some organizations, community-based organizations in Louisville and West Louisville doing some phenomenal work. The last thing we want to do is come in with the big N and say, here's how you're going to do it. And so over the last 6 months, we've met with 12 community-based organizations around mental health, and I think it's called the Behavioral Health Collaborative, just to see what's already being done and how we can collaborate, which is a different approach, but a very necessary approach. Because as I also alluded to in the slide, getting our hands around mental health, it's going to be a challenge. And no one organization has the bandwidth to do it. You try to find a psychiatrist right now, almost impossible. And so we know we can't do it alone. And I think your other question, we brought up some of the utility disconnection rates and digital access. We thought that Wi-Fi was going to be a huge deal, but when we do our community needs assessment and our survey of 6,000 people, that fell down on the list quite a bit. And so I'm not saying that it's not an issue, but here's what the issue is. Even when Wi-Fi is available, African Americans and Hispanics don't trust technology. And this isn't me saying it. I took that slide out. That's what the data says. And so it says that we have to do a lot around health literacy and education, because even when you have the technology, if people don't trust it, you're still at a loss. I took the long way around a lot of your questions there. Hopefully
Representative Brown.
Thank you, Dr. McCants, for your presentation. I came in late, and sometimes I do that when I come to church, and you preached a sermon.
Yes, sir.
And I think your facts and your figures speak to the issues that we have, not just in Louisville, west end of Louisville, or Savannah, or New Orleans, or anywhere else. I think it speaks to the issues that we have in America. And I would like, Mr. Chairman, for us to, Ms. Chairman, to make this a somewhat white paper for what we see as the issues and concerns in the Commonwealth of Kentucky. And when you finished, it was like a drop the mic moment. I appreciate what you said. I appreciate the presentation. Thank you very much.
Thank you, sir. One other comment, you brought up Kentucky. And so what we see in the African American population, you can apply to rural Kentucky as well. And I said segregation, and most people heard racial, but I'm also talking about geographic segregation. And so you look at rural Kentucky and some of the areas that border West Virginia, the healthcare disparities are just the same. Thank you.
Thank you. Representative Heverin, co-chair.
Thank you. What a great presentation. Very eye-opening. You are very direct and to the point, and I appreciate that when we're hearing information. I think it's very strong, and it sends a strong message. I have two questions for you. First, I guess I want to make a comment first. I I think Representative Kulkarni brought up a good point of why is it taking so long to build a hospital in the west end of Louisville, but thanks for doing it now. Thanks for making it a focus now. And I think July of 2020, we say this a lot, but I think it really brought up a lot of conversations that needed to start happening.
Sure.
And, whether that was an indicator of that, yay or nay, but I'm glad that it's happening now because it is. And I think my first question, I read in the Courier Journal the other day how there are 4 Walgreens shutting down in Louisville, and 2 of those would be in Beachmont and Taylorberry neighborhoods, which the one on Broadway by the hospital I think is still would be considered probably used by the West End. How is that gonna? I mean, that's now lack of access to healthcare because I would say there aren't many other pharmacies there. How is that going to affect the West End?
So we will have a pharmacy at our location. Several of the federal qualified healthcare centers that have been providing great work have pharmacies associated with them also. But when you look at
and let me say, I realize you don't work for Walgreens, so I'm not. But I think that really affects the access.
It does. But when you look at the investment that's coming between Norton and Goodwill, I think you'll see more industry pouring into that area. So not really worried about who's leaving. Once that hospital opens and once Goodwill's Opportunity Campus is erected, you'll see a lot of investment coming back into that area.
Good. My second thing is I'm a big believer in that you cannot be what you cannot see. That's why I ran for office. And I think that, I don't match my colleagues sometimes. But I really think that, when I ran, I wanted young girls and young people to recognize they have a voice in government. And I think that's very important. And so to me, this is an awesome opportunity for you all to come into the community and say, hey, these are opportunities you can be when you get older. But what is, when you all are hiring, do you think you'll focus on hiring minority people for the hospital at the West End? What is your all's thoughts on that?
Very, very good and important question. We want the right attitude. We want the right service attitude first. And we hope that comes in a color that mirrors the community, but it doesn't have to be. But our other interest is, I sit here as a cardiologist, but less than 5% of the medical workforce are African-American cardiologists. And so we have to work on our pipeline programs. Notice that I mentioned Simmons College as an HBCU. We're working with Meharry Medical College and Morehouse also to make sure that we have good representation. But your point is well intended. When I'm in the West End, I always have a white coat on so that the kids can see what is possible.
Well, I think to that point, you trust what you know.
That's right.
And that's not. I feel like that just is what it is. And I found it very interesting when you were sharing how your white teachers were the ones that influenced you the most.
That's right.
And I think that there's, I don't know, thanks for sharing that. It's given me a lot to think about. So thank you for that. Thank you, Mr. Chair.
Thank you.
Senator Neal, you're recognized, to be followed by Senator Berg.
Thank you, Mr. Chairman. And thank you, Dr. McCants, for your presentation. I really don't have a big question. I have a couple of observations. One is this is a very complex situation that's deeply rooted. It's going to take heavy lifting to undo on multiple levels, I think you would agree. What impresses me about this is that Norton's, with its intentionality, instead of just plopping in, is doing its research and moving into a space that can make a huge difference in a critical area. And it's that intentionality and the value that you bring to that space that is highly impressive. And I just want to say that I think this is a game changer. And I think if more corporate entities, I'll just use corporate, with capacity and intentionality, move into spaces with the intelligence and research that you guys are doing, and you're going to learn as you go. You don't know everything yet.
Yes, sir.
I think that's going to be a really big deal. The reason I'm saying this is because we can talk about how bad things are, but the fact of the matter is that this was not done by happenstance. This was done by design. It was done by intentional policy, The reference to redlining specifically speaks to that, but there are multiple things that have done that now the legacy of the racism and so forth that not only brought us to this day still exists today. And overcoming that's going to take some strong intentionality. Now, I know those are words a lot of people don't like to talk about no more, but it's the reality. And you can't deal with reality unless you understand what is real, and you work from that. So I want to congratulate your leadership. What they may not know and what I do know about is your leadership in this and the intentionality that you have applied. You are leaders in making the changes that we're talking about on this commission right here, about creating opportunity and dealing with it in a real and concrete way and not in a superficial dress-up sort of way. Congratulations on that, and any support that I and others, I'm sure, on this commission can give, I think you're going to get it. Thank you.
Thank you.
Senator Berg for the last question for this presenter.
Thank you, sir. This was an awesome presentation. My question was brought up by Representative Heavrin a little bit. We have data that shows that if black children have a black teacher in school, they do better. Their outcomes are better, particularly male black teachers. And we know, we just alluded to the fact that even though 20% of our population is black, that is horribly underrepresented in black physicians. 20% of our students are not black. Do you have any suggestions how, with intentionality and purpose, we address that discrepancy as a state?
Wow. So let me go back to your comment. Black kids do better with black teachers. That's not to say that white teachers or Hispanic teachers are not good teachers. Let's not. I want to make that clear. But we see the same thing in healthcare. African American patients are more compliant when they have an African American provider. Hispanic patients are more compliant when they have an Hispanic provider. And we have to accept that, embrace that, number one. So my answer would be to those that are not African American or not Hispanic, just because that patient or student does better with that person, that's not a bad thing. Encourage that, because we need those students to be better so that they end up at the top of their skill set. But I don't have the answer for what we need to do. I just know that we have to build our workforce, and everybody has to get the same message. One of the things Dr. Miller and I were talking about is that often we operate in silos. Everybody is doing good work. Everybody is well intended, to steal Senator Neal's term, but we operate in silos, and you can't do that in healthcare. You can't do that in any service industry where the people or the population depends on you. And so that's our first thing, is Norton has to work with U of L, and we have to be intentional about how we do things, because the workforce needs to see that. Again, long way around, but wanted to make a few points. Thank you.
Just a follow-up, thank you. And I do think, honestly, that we would be better serving patient populations if the people who served them represented what they looked like. I do think it would make a difference to people.
Yes, ma'am.
Thank you.
Thank you.
Dr. McCants, thank you for your time here today. Thank you very much for sharing your talents and passion. Please express our appreciation to Nortons for supporting you in this vitally important work that you're doing.
I sure will. Thank you.
Thank you.
Thank you.
Our next presenter on the agenda today is going to be Dr. Dana Quisenberry from the University of Kentucky Department of Health Management and Policy. Dr. Quisenberry, we're honored to have you. Please introduce yourself for the record. And your topic, based on our agenda, and I'm confident your presentation, is going to be overdose mortality rates among Black Kentuckians.
Yes, thank you so much. My name is Dana Quisenberry. I am an assistant professor in the Department of Health Management and Policy at the College of Public Health at the University of Kentucky. I'm also a faculty associate at the Kentucky Injury Prevention and Research Center. We are currently funded by the CDC. I'll go ahead and get this started so that we can. We are currently funded by the CDC to conduct drug overdose surveillance, public health surveillance. I actually lead the team and the principal investigator on that CDC funding. My colleague, Dr. Terry Bunn, is the principal investigator for the prevention side of that house. We've been doing this work at Kiprick since 2014 when I first started there. And I would like to tell you that I'm coming with good news. But I wouldn't be here if I was coming with good news. So this is not, I have got toughened up and have gotten broader shoulders because I am very rarely appearing with good news. I want to share with you some observations from our last annual drug overdose death report, our mortality report. It actually covers a 5-year period, but with the most recent data, we have some concerning findings. We know that in 2020, we had a 50% increase in drug overdose deaths in this state. It was alarming. It was concerning. We were stressed. We've been doing this prevention work, and others in our state have been doing prevention and intervention work for a number of years. This was very unexpected. As you can see, from 2017 to 18 to 19, we were declining. We thought we were finally getting ahead of the opioid epidemic in this state. I would like to tell you COVID is the sole responsibility for the numbers that we see in 2020, but we actually started to increase in mortality prior, at least 6 months prior to the epidemic. It's concerning. We saw another 15% increase in mortality from 20 to 21. In the world of epidemiology, we try to convert these numbers into numbers that we can compare to others. And that's why we calculate age-adjusted rates, because I can now take these rates and go and compare to any state in this country and be able to say, are we in a better or worse position than some of these other states? And we could also comfortably compare across years in this state. We are at the highest rate and have been for the last 2 years of age-adjusted mortality from overdose in this state. There are several things that we do with this information. One of them is we look at geography, and what's the distribution across our state with this mortality. And as you can see, the age-adjusted rates for the counties that we're allowed to report on, it's pretty distressing. And I will tell you, we haven't been this dark in color on this map in some time. I live in northeastern Kentucky, and as you can see, that I-64 corridor looks pretty distressing, doesn't it? But we also know in our high populated areas, we're seeing increases in mortality, and it's really distressing. We also look based on gender, and we still maintain that for every single female who dies from drug overdose, we have at least 2 males. The rates also reflect this. We also stratify by race. And although the numbers are smaller amongst Black Kentuckians, there is a growing concern because the trend of increase among Black Kentuckians in drug overdose is escalating at a rate that we are not seeing in the white population. When we convert this information to rates, this is actually the first year, 2021, that the age-adjusted mortality rate for overdose for Black Kentuckians exceeds that of white Kentuckians. This applies to all Kentucky resident deaths. This is the drug types that are involved in these deaths, and these are counts, these are not rates. And if you'll see what has happened with the introduction of fentanyl in our drug supply in 2020 and 2021, that seems to be driving nearly, well, it doesn't seem to be, we know it is driving more than 70% of our mortality. Also increasing at similar rates is methamphetamine, which is that blue category on the top right. Mortality is one piece of the picture. What we learn from individuals who have passed from drug overdose helps us determine prevention efforts, but our ability to rescue, save, keep them alive has passed. So we have to take the information from their deaths and try to prevent other overdoses, particularly fatal overdoses. And we know that there is a large proportion of our, nearly 90% of our overdose decedents who have had a non-fatal overdose, at least one non-fatal overdose prior to their death. So this slide here is the age-adjusted rates for emergency department visits for non-fatal overdoses from the same time period of 2017 to 2021. And I would like to draw your attention to the fact that in 2017, when we had the historically high amount of mortality, we also had pretty high rates of ED visits for non-fatal overdoses. And at that time, the rates for white Kentuckians exceeded all other races and ethnicities. That has also shifted. Like I said, this is not great news, although I'm quite encouraged by the prior speakers' attention to the substance use problems in Jefferson County. I was going to say that's the end of my presentation piece, and I wanted to leave adequate time for us to discuss these numbers a little bit more in depth, and we can go back to any of those slides. But we have identified a problem that needs attention in a way that we have not seen that problem in the past. And I'll be happy to take any questions that you may have.
I want to thank you for being here. I don't know that I want to thank you for the presentation.
Please don't thank me for the presentation. That's perfectly fine.
And no humor, no laughter, no smile on my face, none on yours, because these are depressing numbers.
Yes, sir.
The broader category, and correct me if I'm wrong, but I've heard this phrased as deaths of despair. Mm-hmm. This falls into that scope and space of deaths of despair. So speak for just a moment about prior to COVID, you say that we saw this coming.
Mm-hmm. We did.
Expound on that just a little.
I didn't bring the slide with me today, but we also have a way of representing this data in a monthly breakdown. And prior to the pandemic, we were looking at an average of 100 to 125 deaths per month, which is astronomical by itself. You know, that's a small plane crash every month. We started seeing increases in September of 2019. And it is almost a 45-degree angle. Instead of trying to talk about epidemiology terms, let me put it in a geographic or a geometry term. You know, we see almost a 45-degree increase starting in September up until January of 2020. May of 2020 was, by all accounts, the worst month we have ever had. We had nearly 250 drug overdose deaths. We also saw a proportionally similar increase in non-fatal overdoses. It was, on record, our worst month. However, after the pandemic, after we started to get a handle on that issue, we are seeing what we are calling a new endemic level of overdose mortality. So instead of returning to that 100, 125 per month, we are now about 150 to 175 per month. And that seems to be the level that we're going to be maintaining for some time. We've been at that level for about 15 months now. Now, there's variations based on months, but that's the average. So we're a larger aircraft crashing every month.
So would you be willing to sort of go off the record for a moment and speculate, postulate correlations here? What's going on?
Well, we know that, first of all, I have to tell you that none of these answers lie in the data that I gave you now. And I have colleagues that are doing great work doing qualitative work, and doing additional work in this area. This is simply public health surveillance. But I'm glad you asked me to somewhat go off record. We know that addiction is a disease of despair, and COVID has created a lot of despair. We disrupted people's health, it disrupted people's financial stability, and we isolated people. There's data that I have and some survey study that we have done on case fatality rate, borrowing from infectious disease. And that is where you take the number of deaths over the number of cases of infection. And we did a similar type of analysis with drug overdose. And believe it or not, our case fatality rate has not dramatically increased. It's basically increasing a little over a percentage point every year from 2017 until the summer of 2021. What we did see is a seasonality in the case fatality rate. So how do we then get, if it's not more lethal, if the disease is not more lethal, what is going on in the beginning of the pandemic? And what we are seeing is far more incidences of overdose. So the increase in death and the increase in non-fatal overdoses were increasing in similar proportions because the case fatality rate pretty much stayed stable. So it wasn't a question of there's something more lethal. We already know fentanyl's more lethal, but we've been dealing with fentanyl since 2017. That's not the new player in this. The new player is we probably have introduced a lot more despair or things that indicate that we're having more despair.
Okay, we got a lot of colleagues with good questions. Senator Neal, we're going to start with you, and then our colleague, Commissioner Drake, you're on deck. Senator Neal.
First of all, thank you for the presentation and the information that you provided. So you just blew a hole in the information I don't mean as a negative.
It's okay.
Of the information I have been receiving regarding fentanyl. How do you pronounce that?
Fentanyl.
Fentanyl, and there's another drug that's involved that is a very cheap
They are.
drug.
Even methamphetamine.
Yes, and that those who produce that and those who carry that target certain communities, poor communities, black and white,
Yes, sir.
and particularly targeting in black communities, and that the mixing of this now is done in such a way that's, I don't know the correct words to use, but in ways that those who are users, it's more lethal. And you just said that you have information suggested it's not more lethal.
Well, what we see in the differences in the counts and rates for Black Kentuckians, I do suspect what you're hearing is probably accurate. We have a population that was not necessarily opioid using that may have been introduced to fentanyl over the last couple of years, and that's why the rates for that community looks different than the other community. We have known since the beginning of the epidemic that white Kentuckians have been not, well, as we call, they're not opioid naive. I suspect that there is a population in the Black community that were in fact opioid naive prior to the time fentanyl has arrived in their community. And that may be what's driving our excess mortality in that community. And we have seen that shift in the postmortem toxicology, where there is more fentanyl in the toxicology reports for Black Kentuckians than what there had been in prior years.
If I may. So, correct me if I'm wrong. So, because if you look at Indiana, in non-black populations, you find a very high mortality rate happening in certain communities as well that's being reported. But what I think I heard you say is that it seems like there's an introduction of usage of a particular type of drug that there was not a history of in the community. But still, you're not in a position, I understand that, you're not in a position, and this is probably an unfair question, I'm just probing.
Yes.
You're not in a position to, or you have no information or knowledge in terms of those who put fentanyl fentanyl into the community are mixing or using it in a different way that makes it more lethal?
We don't have that information here.
Yes.
And this is not available or discernible from this data here.
Okay.
But we do know from the toxicology that there was a point in which fentanyl became part of the substance use of those individuals. And that is different than what it had been in the past. We cannot discern from people who are not living whether they are looking for a combined product of a stimulant and an opioid, methamphetamine and fentanyl. We can't discern that. They can't tell us that information. We don't know if they're using it cyclically, where they use opioids at some point in the day and methamphetamine at a different point of the day. We don't know that question either, because people who are deceased can't tell us that. We have been starting to do more work around non-fatal overdoses and trying to discern from living individuals more information about how those use patterns happen. And I have colleagues that are doing great work in that. And it is something that needs to be understood so that we can do the type of harm reduction services that are effective for those specific issues.
Thank you very much.
Thank you.
Commissioner Drake, and then followed by Commissioner Roberts.
Thank you so much. Thank you for your presentation. And you may or may not have the answer to this just going off of the slides you presented. And I believe you said that there's like at least one non-fatal overdose before an actual overdose that results in death. And I was curious about, for those that are non-fatal, are they offered help if they are arrested? How often, when you look at race, when you look at who's in rehab, who gets the help, and I don't know if you all have done that, like how many white people are offered rehab versus black people being offered going to jail or being able to get more access to drugs. And even if they are arrested, they can certainly, we know, access drugs while they're behind bars. So I don't know if you've done that. And then secondly, if I could ask you, and you may not know, but you did mention May of 2020 and an increase in despair, and you mentioned COVID. Have you all looked at racial injustice and what happened in Kentucky in May of 2020?
To answer your first question, you're right. I can't provide you from this data an answer to that. And I wish that I could. And I think it is an important question that needs to be studied. There are communities in this state that are starting to stand up response teams that will go do a hand-to-hand touch with people who have survived a non-fatal overdose. I think there's now 17 or 18 of those teams. Now, whether or not there is one of these teams doing work in this particular community, I am not aware of one. So that would be a great place to start, of being able to offer that as a service, to be able to do that work with that community. Access to treatment is a significant problem in this state, even as we continue to develop providers that are licensed to do buprenorphine. As we continue to increase the methadone clinic footprints, access is a real issue. And I don't expect it to be different than regular health care from the standpoint of being a problem. But I do think it's probably more significant of an issue just due to the stigma that's associated with substance use. And I think that's true for both white and black Kentuckians. But then you compound the lack of access for individuals in the black community. I suspect that it is even a more significant issue there. But this data doesn't speak to that. But if you are interested in some more information about that, I can try to get that for you. And your second question about racial injustice, once again, this data doesn't speak to that. But you are absolutely right that we will be unpacking the events of 2020 as researchers for probably the next decade. To being able to understand the effect of COVID, the effect of racial injustice, even the fact that the people had fear of even going to a medical facility during that time, and that whether or not that delayed care for other conditions. We have a tremendous amount of work to understand so that we can potentially prevent this cluster of events from happening again and having the effect not just over on overdose mortality, but other mortality and the excess mortality during this time.
Commissioner Roberts with Dr. Oleka on deck.
Good afternoon, and thank you for your presentation. So I work at the Commonwealth Attorney's Office in Jefferson County, and our office, like a lot of other Commonwealth Attorney's offices and county attorney's offices, have set up heroin rocket docket programs in our jurisdictions. Been very successful. For those who aren't familiar with those, they're dockets that encourage, steer, and sometimes direct folks who are involved in the criminal justice system, usually at lower level offenses, into treatment versus into custody, jail, or prison. And one of the things that I know that we've seen is our issues with access to treatment, kind of along the lines of what Dr. McCants was talking about, access for addicts to treatment. Can you speak about that and where we are at all as far as in the Commonwealth? Do we have enough treatment facilities for the ones that we do? And a follow up on that one, for the ones that we do have, are they private? Are they nonprofit? Are they government funded? Are they government operated? Just to kind of get a feel for what the treatment spectrum looks like.
Well, I'm going to direct you to one of our prevention efforts that's associated with our Overdose Data to Action program. It's called Find Help Now, KY. It is a catalog, so to speak, of the treatment options that are available, but it doesn't operate in the same static catalog like it's just a list of places. When you go to that the site, you can actually put in the parameters of what you're looking for, and it will only deliver to you in results facilities that have an opening right then. And I'm going to share with you, Commissioner Roberts, I was a practicing attorney for 15 years, and I have had the horrific experience of having to tell someone's mother, we have to charge your son with the checks that he stole so that we can get him into treatment. It's not a pleasant place to be. But it also taught me very quickly that there's a window of opportunity when someone is ready for treatment or feels that they have to go to treatment, which sometimes isn't the best alternative because they may not take it seriously. But that's why the tool of Find Help Now, KY, of being able to give you an open, available treatment slot is so important. And it's now been active for 3 years, and we're very excited about what we see. So we have built into that every level of provider, including buprenorphine providers. And we only let them stay on the website if they will update their availability, so that we don't have an opportunity where a result will show up and that bed's not really available, because that's discouraging. And it's available publicly. Anyone can use it. Matter of fact, it'd be a great tool for you all to be able to use in your program. But we're doing community work about 15 years ago when the Appalachian Regional Commission issued a report saying that Kentucky was doing substance use treatment the best of any state in the region. And I was like, what? I know, I saw your reaction too, my same reaction. We have made vast improvements since that time, and we continue to make improvements. Do we have enough? I'm not certain. Do we have the connections to get people into the treatment that they need? That connectedness is the most important piece of access.
Could I ask one other quick follow-up? Thank you. That's very helpful. And I noted that. I'll make sure our folks have access to that if they don't already. For the folks that you're tracking for the overdoses and over the time period here, do we have any data on how many of those folks actually had any treatment before?
We actually do have some of that information. There are some of the parameters we're catching of whether they have been incarcerated prior to their death, because there are some substance use programs in our corrections facilities, whether they are recently have been in treatment. one of the things that we will be doing now that we have enough years of data to be able to do some trending and understand what's really been going on and those opportunities to intervene. We're going to be doing some more work with that. So hopefully I'll be able to tell you more about that if I'm invited back.
Thank you. Thank you.
And I'll also let you know there's another tool, Find Recovery Housing now, that may be helpful for you that we've stood up as an ancillary site to that. So that transition in providing sound housing for individuals early in their recovery, that site will help you find that as well.
So we have some more questioners, but before we do, you've said a couple of things that piqued my interest, and so I'm going to use my prerogative as chair. First of all, yes, you are invited back. This has been very engaging, and I sense a lot of interest in what you're doing. Secondly, I've long had an interest in trying to discern those treatment programs that are successful versus those that are not, so that we can build a performance rewards model to move forward those that are successful and to maybe incentivize those that are just collecting money on a fee-for-service model and not producing outcomes. So if you could put something together for me for future reference, I would appreciate it. Dr. Oleka, you're next, to be followed by Senator Berg.
Thank you, Mr. Chairman. Earlier, the chair mentioned the term deaths of despair. This is not my area of research, so the comments I'm making are more anecdotal based on what I've heard and what I've read, and I'm hoping you can clarify some things for me. The way I understand it, these deaths of despair are particularly harmful for men, particularly between the ages of, we'll say, 18 to 50, to give a very broad range. I'm going to ask you a few questions about variables and whether or not you all have looked at these in terms of how they could relate to substance abuse-related deaths. Marriage, education, and then income/employment. Again, based on things that I've read anecdotally, I hate stating things as fact without being able to cite the research behind them, but from what I understand, for men, these things are particularly beneficial: work, marriage, being educated. Have you all collected any data as it relates to these, and could you speak about that, please?
We have collected that data. Whether you're married at the time of your death is on the death certificate, uniform death certificate, so we have that information, as well as the education level is also on there. Their unemployment status is sometimes captured on there because the death certificate specifically asks last known occupation, and we have noticed there's some inconsistencies in that particular field of the death certificate. We are in the middle of doing a study about the pandemic effect on unemployment and the study on the changes in employment during COVID by industry, and we'll hopefully have that paper out in the next little bit. We do know that our service industry took a pretty significant hit, and they're a population that, by and large, stays employed, but has some significant substance issues in it, and so we're hopefully we'll have the data on that very, very soon for you, and I can make sure that gets to you.
Great, thank you. And then just real quickly, marriage and education. Do you know if there's any correlation between men who are not married and their... When you look at the death certificates, do you see more unmarried men than married men? Have you done a study on that?
The last time I looked at that would have been 2019 when I did my own dissertation. And yes, marital status, if you were single, separated, you did have there were a higher proportion of those individuals in the population at that time.
Thank you.
Thank you, Dr. Berg. Senator Berg.
Thank you, ma'am. Again, very, very interesting. And I don't necessarily expect an answer to this today, but I would like to know, has Casper worked? Initially what I thought I saw is once we sort of closed the pipeline to legal drugs that were being abused, that opened more of a pipeline for illegal drugs to be abused and unregulated drugs. And then I sort of thought, well, that's all steadying itself out. But it looks like it hasn't steadied out, that it's actually getting worse. So am I reading this wrong?
Casper has been a wonderful tool. And early on in the epidemic, when the epidemic was being driven largely by prescription opioids, it was a much needed tool, and it has served a wonderful purpose for that, addressing prescription opioids. I know there's a lot of concern about the transition from prescription opioids to heroin to now what is fentanyl. And I will tell you that there was heroin present in Kentucky before 2012 when that bill was passed. Matter of fact, starting in 2013, it did become one of the major drivers of drug overdose in this state, but it had already been here. I try to characterize in my own mind is that we have a population that is opioid dependent. And there could be some conversation around this concept that when there's the whole economic supply demand type of thing, until the last few years, the demand side has been kind of light on the intervention. And now that we have more treatment available, more opportunities to address the demand, it's just going to substitute one after the other. So it's not really a true transition from one substance to the other as long as we have a population that is opioid seeking. Because as you can see, I put back up on the screen, we still have 218 deaths in 2021 that involved a prescription opioid. That was, we had 2,256 deaths. So they say don't speak in public. You also shouldn't do math in public, so someone else is going to have to do that math. It's still, present in a lot of overdoses. Now, to let you know, these, and I should have said this when we talked about this, these are not exclusive categories. Almost, I think in the last 5 years, we've had only one death that's been from a single substance. It's all polysubstance. And so there could be a presence of a prescription opioid, there could be prescription of fentanyl, until the last couple of years, heroin could have also been present because individuals who are in active substance use, it's kind of addiction is a disease of opportunity, and so it has to that has to be fed. So whatever is available is what's going to be consumed. The questions about early in 2017, some of the reason the increase there was the introduction of fentanyl and its analogs. And there were policy changes that happened internationally as well as locally, and we seem to see that at least the analogs started to be addressed. I've done prevention now. I said this to my students. I've been in this game for 25 years now, and we used this anecdote poorly then, but I almost feel it's as true today. We play whack-a-mole. We can knock a substance out, but until we address the demand side of that equation, we still have some issues that we're always going to have these issues.
Thank you. And then we have our last questioner for this presenter is Representative Cole Carney.
Thank you, Chairman. Thank you for your presentation. I had a question about this slide in particular, and I think you might have touched on it. My question was just looking at the graphs, right? You've got an increase in fentanyl, you've got an increase in methamphetamine. Prescription opioids look like they're fairly steady in terms of use. Heroin has gone down in the same time period. I wondered if you had a breakdown in terms of race and usage of each drug. You just mentioned in answer to Senator Berg's question that there may be multiple substances involved. So my question was, is it possible to get that breakdown? And are there any highlights, like have you seen anything in the data in terms of drug usage by race specifically? And then my second question has to do with the site. I went to findhelpnow.org, which is, I guess, a University of Kentucky initiative. And there's several partners listed on that site, including CHFS, Kentucky Public Health. My question was, in terms of this site, which is very helpful because it goes by your location, right? So it'll say there's a treatment center half a mile down the road.
Yes, ma'am.
What is your budget or scope for outreach for this particular site and the information in it?
Okay, thank you. let me deal with the toxicology piece first, because that's really my bailiwick of the grant. We do know that, and that I made reference to a little bit of that with my response to Senator Neal. We have seen a transition from a primarily stimulant using population to more of a combined stimulant and some type of opioid, usually fentanyl, in the Black community. And that's that whole conversation around they may have been opioid naive, and that's why we've seen a more dramatic increase of overdose amongst that population. But I can get you more specifics by race. Now, we did a paper in 2020 that is in JAMA that has some of that information, and I can send that paper to you. I'm going to make a note of that so I actually remember to do it, okay? The other question about budget. When we first started with OD2A, the prevention side, we stood up the Find Help Now. We heavily invested in media. And we still have that same marketing firm that is helping us with it. What we are finding, it doesn't matter how many messages we push out, how many ads we run, whether we buy social media ads. I come to like a hearing like this, and there's still maybe 1 or 2 people that have heard about it. And the only thing I can reconcile in my mind is that perhaps we're not marketing in the right place, or people don't pay attention to the marketing when they don't have the need. And once they have the need, then they don't recall the marketing. And I'm not sure we can do anything about that, but we're getting ready to invest another $500,000 in marketing for the next 10 months. Our OD2A funding ends August of 2023. We'll be writing competitively for that again in the spring, and this will remain one of our initiatives. But if it could be more heavily resourced, as any good message going out, you need at least 15 good messages to outweigh the one bad message, and public health in particular. We're not resourced to do 15 messages to one. Thank you.
Dr. Quisenberry, thank you for being here. Thanks for your presentation. I wish we could say we don't need your services anymore, but sad you're in a space that we're going to continue needing your services, but let's do work together. Bring us those data pieces to drive information, which results in policy. So
Absolutely. Thank you, sir.
Thank you very much.
I appreciate you. Thank you all.
Appreciate that.
Like I said, I wish I had had better news, and perhaps when I return, we will place some interventions into this community and we can see a positive impact. So thank you so much for your time.
Thank you. We're going to go a little bit out of order in order to continue building on our conversation around trends, data, and health outcomes. Dr. Berg, if you would like to introduce our next guest and invite them to the table, remember to tell them to turn their microphone on and introduce themselves for the record.
All right, put me on the spot, guys. This is Dr. Miller, who is here at my request because he is one of perhaps the leading African-American authority on maternal mortality and obstetrics and gynecology in this state. Chair of the Department of Obstetrics and Gynecology at University of Louisville School of Medicine, where we train our OBGYN physicians in this state. And sir, I personally thank you very, very much for being here and sharing your knowledge with this committee.
Thank you so much for having me. Can everyone hear me? Okay, perfect. Thank you for that introduction. I'm Edward Miller. I am a fetal surgeon and maternal fetal medicine doctor. It's been fantastic to be able to sit here and listen to these presentations. I hope to build on these and really approach them from the lens of maternal health and pregnancy. There's been so many fantastic questions, and as I've heard them asked, I've always wanted to reframe them for what about women and what about pregnant women, because the answers are oftentimes quite different. So, as we've talked about today, and as Dr. McCants mentioned before, health outcomes are multifactorial. So, when we look at things like maternal mortality, maternal morbidity, we can't look at the end outcome. Maternal death in pregnancy, maternal near misses during pregnancy. We have to think about everything that led to those outcomes. I ask my residents quite frequently when a patient comes to their office is, how did this patient get to you? And when they're interns, the first response is they took the bus, they walked, but it's bigger than that. How did they get here? And then once they answer that question, how did this healthcare system that we've created, that we're working in today, contribute to the disparities that these patients are facing? So when we have near misses at U of L, when we have adverse outcomes, we use this model. We look at the social and economic factors, the clinical care that we provide, patient and provider behaviors, and the physical environment that the patients are growing up in to determine what led to those adverse outcomes. So I don't need to go back here because Dr. McCants talked about this beautifully. I have been in Kentucky about 2.5 years, moved here from California, and I was immediately struck by how sick our young people are here in Kentucky. At the University of Louisville, we have a very unique patient population. We serve the urban Louisville population, but we also, as a referral center, get patients from the rural counties of Kentucky. So we see hypertension, we see diabetes, but we see it from an urban perspective, and we see it from a rural perspective. And it's amazing how the same disease entity presents quite differently, but ultimately leads to the same adverse outcomes that we're seeing. And where you live is critical, as Dr. McCants mentioned. In Louisville, if you live in West Louisville, your life expectancy is 12 years shorter than those of your neighbors. But life expectancy is one thing, but what about on the flip side? What about how your life gets off to, the start that your life gets off to? We'll talk about the rates of preterm birth, but all of these are linked. With almost any chart that you look at for preterm birth, adverse fetal outcomes, NICU admissions, you can overlay that same chart onto this one and it would match almost exactly. So healthcare disparities that we're talking about globally, not just in women, not just in pregnancy. So this 2019 data looked at all the states and found that Kentucky ranked number 1 in terms of cancer death in terms of disparities, number 3 in terms of obesity, number 4 in terms of drug overdoses, 9 in heart disease. You can see the list goes on. And I want you to think about which of those affect women of reproductive age. So we're looking at minimally cancer deaths, definitely obesity, definitely drug overdoses, as we'll go into later. And we'll be amazed to see at the rates of heart disease and diabetes end organ damage in young people that are pregnant of childbearing age in Kentucky today. So numerous medical conditions shorten Black lives. This is just the fact that we're living in. Kidney disease disproportionately affects African Americans. Stroke, cancer, heart disease literally takes away, on average, 13.4 years from the Black lives. Now, this disproportionately affects Black men, but it affects Black women as well. 86% of this discrepancy is preventable with medication, early access to care. But as we'll talk about as we break down some disparities that we see in pregnancy, the reasons behind why these disparities are there are so ingrained into our healthcare system, into the society, and the stereotypes and microaggressions that our patients are seeing every day. So as we enter this talk, some key terms. So when we talk about pregnancy or maternal mortality, there's numerous steps in the lead up to it. So we have pregnancy-associated death. That's death while pregnant or within 1 year at the end of pregnancy, irrespective of the cause. So it may be a car accident that's not related to pregnancy. It may be some other sort of accident. Those are all reported in pregnancy-associated death. You have pregnancy-related death, which is next. This is death during pregnancy or within 1 year at the end of pregnancy from a pregnancy complication. So this is where we need to focus our efforts, a pregnancy complication, whether that be hypertensive disorders, a blood clot, a bleeding disorder. And finally, it all ends up in maternal mortality. Death while pregnant or within 42 days of the end of pregnancy, irrespective of the duration and site of the pregnancy, from any cause related to or aggravated by the pregnancy or its management, but not from accidental or incidental causes. Now, I'd like us to think about maternal mortality, which we hear quoted quite frequently, and pregnancy-related death. I would hypothesize that both of those are just as impactful for the patient, for the family, for the individual, but we oftentimes quote maternal mortality as opposed to pregnancy-related death. There's reasons for that, and it's all in that number, 42 days. 7 weeks after delivery is when we stop quoting maternal mortality. And 7 weeks after delivery, many women who are uninsured, who have the highest risk of baseline complications, who obtain insurance during pregnancy, then lose it and are uninsured. And whether or not they had congestive heart failure that they developed during pregnancy, whether or not they had poorly controlled diabetes, they lose that insurance. And as a result, rather than keeping track and reporting pregnancy-related death, we choose to report maternal mortality because our numbers look better. It's cherry picking. So as we look at this, I want us to recognize that maternal mortality is one part, but really pregnancy-related death, which is less often reported, is what we should be looking at. So this is all-cause maternal mortality rates in the United States. So these are 55.3, if you look at this African-American rate in 2020, that's per 100,000. As you can see, from 2018 to 2020, the rates of maternal mortality rose across almost all demographics. But if you look, the rates amongst African Americans are highly discrepant compared to other groups. And it's important to recognize that this is not new data. This has been around for years. We've known this for years. And as we talk about the impact of COVID with some new data that's come up, the rates are only rising. So how are we doing in Kentucky? So when we look at women in Kentucky, and as we all do our research and look into the topic of maternal mortality, as you do research, as you read articles, you'll oftentimes see them entitled papers, Women and Child Health. Women and Children's Health. So we lump them together. I've never seen an article about men and children's health before, right? Because there's a reason for that. Because when you lump it women and children's health, we're then forced to choose what is the outcome. And the outcome that we've chosen is children, is babies. So we focus on things like how are prenatal outcomes? What happens to the babies? There was years ago, one of the most landmark changes in obstetrical care that changed how babies do is the administration of steroids when babies are at risk of delivering early. We found that when babies are delivered early, around 24 weeks, and they get steroids, their survival rate goes from 50% to 75%. It literally changed the game. The person that came up with this won a Nobel Peace Prize. But one of the things we don't talk about is there's been this study, the steroids took years and years of data, but if we had actually looked at the data, we would have seen that steroids and knowing the benefit of steroids should have been seen much earlier. So whenever we're stressed, whenever we have a stressful environment, our body releases steroids. It is one of the things that contributes to the fight or flight technique. What we know from looking at NICU data from years back is, do you know which babies, if you're taking babies born at 24 weeks of gestation, do you know which babies are most likely to survive? Black females. Do you know which babies are second most likely to survive? White females. Then black males, and finally, white males have the least chance of survival. And that's because of this basic stress that comes with womanhood, with being female, and this basic stress that comes with being minority. Women, black women that are pregnant have constant elevated levels of stress, which is well documented, and their babies, there's a reason why their babies do the best without any intervention. And this chart points to why. So this chart right here looks at social and economic factors and how Kentucky rates against other states in the country. When it comes to social and economic factors, Kentucky ranks 42nd in the nation, and it's because of areas right here. So when we look at, they have high rates, women have high rates of intimate partner violence before pregnancy, high rates of food insecurity, a large gender pay gap, high rates of poverty. And then if you look at other aspects, health outcomes. We have high rates of tobacco use compared to other countries. There are high rates of high health status, so presence of diabetes, hypertension, heart disease, multiple chronic medical comorbidities, and obesity. So all of these factors lead to the fact that when women come to my office, they are sicker. Now, the thing is they don't feel sick, because what I always say is no one says that their diabetes hurts. No one says that their high blood pressure hurts. It's a silent killer. Women come to my office at 18, 19, 20 years of age, but not every year is the same for every individual woman. Women come to my office with signs of end organ damage, kidney failure at 22 years old, of no fault of their own, of a fault of simply how their upbringing was, what their resources were. So when we look at causes of maternal death in Kentucky, and again, this is maternal mortality, the most common cause is accidental. So we're pointing that to things like substance use disorders, heart attacks, those kinds of, or not car accidents, those kinds of things. Then you have natural disorders, which are things like chronic structural disease, suicides, and homicide. When we look at Kentucky, we know that most recent data from 2020 showed that overdose is now the leading cause of maternal mortality in Kentucky. It used to be things like heart disease, renal disease, or strokes, bleeding disorders, but now it's overdose. Opioids are the main cause, and methamphetamines. So our last speaker talked a lot about resources to people during pregnancy or during have substance use disorder. But during pregnancy, those resources are slashed dramatically. During pregnancy, if you live in a rural county, you may have to drive over 45 minutes to a provider that will prescribe medication-assisted treatment, methadone or Suboxone, to you during pregnancy. The amount of providers or the access you have during pregnancy is slashed dramatically. Now, that provider may prescribe you that medication, but they may not be an OBGYN. They may not be able to take care of you during your pregnancy. So then you have to go see another OBGYN, another doctor, to get your prenatal care. Let alone the fact that statistically, these pregnant moms have access to less resources. So it's really setting these moms up for failure from the very beginning. And to go back, we talked about, so what are barriers to getting these moms in for medication-assisted treatment, methadone or Suboxone? So we know that there are disparities in things like CPS. So many pregnant women are afraid to come into the doctor because the first question they ask you is, will my baby get taken away? And you can't answer that question. But we know there are disparities in how frequently CPS gets called for Black women versus other ethnicities. For a matter of time, we'll go through. And this slide is just to say that rural women, as we know, are disproportionately impacted by maternal mortality, and that mortality increases when we look at minority women in rural communities. So this is relatively new data that looks at 2018 through 2021, and it shows that COVID-19, the COVID epidemic, has significantly exacerbated the rates of maternal mortality. We see that in 2021, there was a significant increase in the levels of maternal mortality, and 400 of the 1,178 deaths that occurred in the United States in 2021, 401 of those were secondary to COVID-19, and that far outpaces the non-obstetric population. The study that looked at these COVID-19 deaths during the pandemic found that the maternal death rate for Black or African-American women was 44 per 100,000 live births in 2019, and then increased to 55.3 in 2020, the beginning of COVID, and finally 68.9 in 2021. And that far outpaces the 48.7 that was found earlier, or 55.3 that was found in African-Americans earlier. And it's not just maternal mortality. As we talked about, it's about getting off to the best start in life. And preterm birth rates in Kentucky, every state is given a grade by the March of Dimes with a goal preterm birth rate of 6%. The significance of preterm birth is immense. So it's not just about admission to the NICU. These babies are more likely to have chronic medical conditions, COPD, asthma, high blood pressure, failure to thrive. And those comorbidities, both in the early neonatal period and later in life, place significant stressors on families. The preterm birth rate for African Americans from 2016 to 21 has risen linearly. It's the highest that it's ever been. It's upwards of 14% total preterm birth rate. The most important slide, this early preterm birth rate. So these are the babies that are at highest risk of these adverse outcomes. Early preterm birth means birth before 34 weeks. That is somewhat rising, it's somewhat steady, but still the early preterm birth rate is at the goal in African Americans of where they want the overall preterm birth rate to be. So overall, looking at it, Kentucky from the March of Dimes gets a grade of D in terms of preterm birth. So takeaways from this, because I hope to have a really nice discussion. Today, Black and white maternal mortality disparity is the largest among all conventional perinatal health disparities. It's the largest that it's ever been. Black women consistently experience 4 times greater risk of pregnancy-related death than white women. This is independent of age, purity, or education. So in short, nothing protects Black women from dying in pregnancy. Not education, not economics, not being an expert on maternal mortality. That's what the studies show. Black women are more likely to die from complications of hemorrhage, hypertensive disorders, and cardiomyopathy. And national data sets revealed that Black women did not have statistically significant greater prevalence of common disorders during pregnancy, like preeclampsia, eclampsia, than white women do, but they were 2 to 3 times more likely to die from these conditions. So they occur at the same rate, but they're 2 to 3 times more likely to die from them. And there's a fantastic new article out that in kind of the obstetric world is really taking over. And it's the takeaway is that the causes of these disparities is not race, it's racism, known or unknown. And I'll end with this quote from Dr. Martin Luther King, because Dr. McCants started with one. And it's, of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. So with that, I'll take questions.
Great presentation in the line of a really good series of presentations today. I've torn out a page that I'm going to carry with me. Your rankings. Kentucky Health Disparities ranks number 1 in cancer deaths, number 3 in obesity, 4 in drug overdoses, and on down the line. When we focus on disparities among white and non-white communities, do we do better, the same, or worse in Kentucky as other states? Is the disparity greater here, lesser here, or similar to it as it is everywhere else?
We do worse when it comes to disorders that are more common. So diabetes and hypertension, we do worse. We do worse when it comes to conditions like lupus. So I'll use the example in Louisville. In Louisville, we have not one rheumatologist that sees pregnant women. So the closest doctor for a Black woman with lupus to go to is in Lexington. And that's what they have to do. So what happens without that is if they cannot go to Lexington, you have internal medicine providers not trained or as trained to treat women with lupus doing their best to treat them. So in states where there are concentrations where hypertension and diabetes, for instance, has higher proportions in Kentucky than in other areas, our providers are overwhelmed.
To what would you just attribute the disparities? Is it access to care? Is it conditions in communities? What's the answer?
From an access standpoint, I'll speak from my personal experience. I am the only maternal fetal medicine physician at the University of Louisville. They have 4 at Norton Healthcare, and 1 at Baptist. So in a city that delivers 14,000 babies, there are 6 of us that are taking care of every high-risk woman, that are taking care and reading and interpreting every ultrasound. So there's 6 of us for 14,000 women. So I am booked out for 2.5 months for new patients. So you don't have 2.5 months during pregnancy, but that's all you can do. When it comes to other aspects of care, so there's the distrust of the healthcare system. I mean, that's its own separate talk. But it comes back to what does it take for this patient to get into your office, right? So if I have a mom who has Black women are more likely to be pregnant with a young child. If I have a mom that has to take city transportation to get to my office, and then she gets to my office and she's 10 minutes late, and the healthcare system shames her for being 10 minutes late, and then says you're not supposed to bring a young child to the office, and then she has to say, I don't have money to take an Uber back. How likely is she to come back to my office? Less likely. Mm-hmm. There's so many reasons for it, but the system is built to shame in many ways women with less access, even though it should be caring for them the most.
Wow, well said. All right, we have a number of questioners and we have limited time, but we are going to spend as much time as we need here, and then we will continue to do all we can do to get this fine agenda finished. Representative Kulkarni, you're first, to be followed by Commissioner Drake.
Thank you, Chairman. I'll be quick. My first question was on that 5th slide that you had with key terms, and you mentioned that we should be focusing on pregnancy-related death versus maternal mortality, and you said pregnancy-related deaths are less reported. Mm-hmm. Why is that? And then my second question was, near the end of your presentation, you had, I think, 3 points. The second one, like Black women are less likely to enter prenatal care in the first trimester. And the second point is they're less likely to receive adequate care. Why is that? And does that have anything to do with them not being listened to in terms of they think something is wrong, but their physician is not?
Absolutely. So
paying attention.
this is my opinion for why I think we don't report pregnancy-related death. I think that if maternal mortality has reached such a level of public consciousness and we've recognized that there's disparities are here, what would we have to do if these numbers were doubled? Because we know that in moms that there's a higher level of death that occurs, especially in women with chronic conditions, if we were to go out a year and follow them. So if we stop it at that 42 days, what we're saying is we're catching the sickest, we're catching the ones that were probably most likely due to acute pregnancy events. But pregnancy is extremely hard on the body. It's extremely hard on the heart. It's extremely hard on the kidneys. And to think that, ask a pregnant woman who had a C-section, are they back to their normal self in 42 days? No. But we don't follow them out because we don't want that data. I don't believe that we want to report on numbers that high because it would force much more outrage and much more focus on having to put resources into this. And it's the answer to that is really, really difficult. It's going to take a firm commitment in terms of access to care that I don't think a lot of people really want to have that conversation about solving yet. And when it comes to why women come to the doctor later, there's multiple reasons for this. It's distrust of the healthcare system. It's many women who African-American women in particular, have irregular cycles because of things like fibroids or chronic conditions and don't know that they're pregnant. It's fear of, especially for young women, fear of what parents are going to say. There's so many reasons behind it. But ultimately, what we do know and what data has shown is that all of those disparities, while still present, are improved when the obstetrician gynecologist looks like the patients that they're serving. So we mentioned that before, but those outcomes are improved significantly.
Commissioner Drake, to be followed by Co-Chair Heverin.
Thank you, Dr. Miller, for your presentation, and especially thank you for saying it's not race, it is racism. I do appreciate that. I wanted to ask you, in your professional opinion, that would you say supporting pregnant women with resources like access to health care and food stamps and things like that would help them, or would cutting food stamps hinder them and their children later?
So not only would it help them, but we at U of L are piloting a program that's entitled Her Best Life. And it's all about what if we supplied these resources before something bad happened? What if we didn't wait to find out that a woman was food insecure? So we've done things like partnered with Dare to Care, a local organization, and we now have a food pantry in our clinic. We now screen everyone for food insecurity when they leave so that they can not only come to get their prenatal care, but they can leave with groceries as well if they need it. I think that not only would it improve pregnancy outcomes, it would enforce more trust in the system and ultimately improve long-term healthcare outcomes.
Thank you so much.
Co-Chair Heverin, to be followed by our last questioner for this presenter, Dr. Oleka.
Thank you. I appreciate this. Is a great presentation, and this is something near and dear to my heart. One of the first set of bills I passed was a bill over for the child and maternal fatality annual report to include demographic information, so race, income, and geography, because I feel like I think we need data, right? I mean, that's what we need, data before we can make good policy. And so until we really know where these are happening, and I had some pushback from the cabinet too. They don't want to do income. I'm like, well, are they Medicaid or not? I mean, that's a pretty significant income acknowledgement right there, because it shows that this affects socioeconomic backgrounds, which, what do we need to do more of? Or is this everybody? And so I think this has been a very well thought out presentation. I appreciate you taking your time.
Of course.
And I just think about, I'm from Litchfield, Kentucky, Grayson County, which is about an hour and 15 minutes from Louisville. And if we have pregnancies that are high risk, we come to Louisville. So you're not only serving, the 6 doctors aren't only serving, 14,000 people in Louisville, it's also the rural areas around it, because we don't have access to care like that. And so that really gives a good perspective and how we can partner with the hospitals at so many levels. I sit on my local foundation hospital board, and it's really, foundations can play a key role in that, of being able to provide resources better than government can to you all. They can provide different perks. So thank you for that that acknowledgement. But I would like to ask you to follow up as time goes on, with this data that we're getting, with the demographic data, if there's, strategic things we can do as a General Assembly to help with that in areas, we want to do that. And that was the point of getting the data, so we can really dive into that and saying, okay, these are where the maternal mortalities are happening. And I really liked how you brought in the second one, the pregnancy-related deaths, because that's one that we really miss out on a lot, I think, here in Frankfurt. So I challenge you is when we get these numbers, come back to us with solutions, because that's what we need. And it's much easier for you, feet on the ground, coming up with a solution than it is us in Frankfurt. Sometimes. So
Absolutely.
Thank you for your presentation, and I look forward to working together.
Thank you so much.
Well stated, Co-Chair. Well done. Dr. Oleka for the last question.
Thank you, Mr. Chair. Thank you for the presentation. I've got a definitional question and then a question that might sound naive, but I think it's important that we're all on the same page here. You mentioned this last report that's popular among obstetricians now. You said the quote, "It's not race, it's racism." Can you define racism as you understand it from a healthcare perspective? That's the first definitional question. And then two, how might that be actualized in a way that would be demonstrably harmful to patients? And again, that one might sound naive, but I think it's important that you, as somebody who does this kind of work every day, my sister's a pediatric gynecologist, so she'll often see the women and sometimes the kids about 5-10 years after you do maybe. So I've heard some of this conversation before. I'm curious, again, how you would define racism as it relates to healthcare and the healthcare industry. And then two, how that might be actualized in a way that could be demonstrably harmful to patients.
Yeah. I think racism is a term that seems like it has such an easy definition, but it's so hard to define. So from a healthcare system, I think racism is the system that hospitals, employees, decision makers, insurance companies, everyone that touches and supports the system, it is the system that is promoted that leads to adverse, inequitable, or unequal healthcare outcomes amongst groups. I think that there are so many examples of how racism plays. So if you look at if you look at on a big picture, let's look at, for a long time, we actually had racism ingrained into our everyday to-day work. So if I ordered a lab, and if I ordered a lab on you versus Senator Berg, and I was looking at your kidney function, we know that African Americans are at increased risk of having certain elevated kidney markers. So rather than identify those African Americans with elevated kidney markers and simply say, we need to watch them more carefully, that would have led to too much influx in the healthcare system. So instead, we said, your numbers are one set, is normal, but for you, we're going to raise the threshold so that we don't have to see as many of you back. So we're going to catch you at stage 1, and we're going to catch you at stage 3 kidney disease instead. Those are systemic levels of racism. We have things like when a woman has a C-section before and she wants to have a vaginal delivery, we have a calculator that determines what her success rate will be for a vaginal delivery. Race is a part of that calculator for years. Black women don't have different pelvises than white women. Black women don't push differently than white women, but it literally went in and it was a negative marker. So black women had more cesarean sections. That's like systemic in what we do day to day, but it's everywhere. It's who answers the phone. It's whether or not we have consent forms in your native language. It's everywhere, and it requires a non-stopping review of your systems and practices in order to make sure you're doing your due diligence.
Thank you.
Please plan to come back.
Absolutely. Thank you so
Well
much
done.
for having me.
Thank you for your passion, your dedication, and truly.
Thank you so
very
much.
Great presentation. All right, 2 items for our colleagues as Senator Westerfield makes his way to the table. In your packet, I want to draw your attention. But let me start by saying, if we ended the movie now, it'd be a great movie. This has been a fascinating discussion, debate, and conversation. But like any good movie, we're going to give you a taste of what lies ahead with a great discussion here around some legislation that we potentially have before us. And that's our tease to cause you to take a look at our discussion for our final meeting, which will be happening next month. There's a single page titled Legislation Discussed During the June Meeting. Brandon and Brett have put this together along with any other ideas that committee members want to add for us to discuss in our final meeting coming up here in November. A lot of what we're going to be doing in November is going to be built around the sort of conversation that Senator Westerfield is going to be leading us through here regarding the Crown Act. And Senator Westerfield, we're honored to have you at the table. If you and Terrence Sullivan would both introduce yourselves for the record. Terrence, great to see you again here. Appreciate your work with me yesterday. We had a good debate and discussion and a fine presentation there at the summit. So, Senator Westerfield.
Mr. Chairman, thank you. Madam Chairman, thank you both. And I appreciate you all making time for this bill on the agenda today. And I realize we're maxed out on time. But first, I want to commend you both on a fantastic agenda and for the presenters that we've heard from so far. I agree completely. This has been a fantastic meeting and an eye-opening meeting. A lot of really rich information to dig into and to hear. So I'm thankful for that. And I'm glad to bat cleanup here. This is about the Crown Act, which is nothing new to the members of this committee and particularly the legislators in here. This is a pretty straightforward bill that makes very modest changes to two chapters in our statutes, our Civil Rights Act, Chapter 344, and Chapter 158 of KRS, which relates to the conduct of schools. And very simply, it protects the hairstyles that are culturally important to the children that have them. Now, I'm white. That's not breaking news. But my kids aren't. And before I had my two precious babies, this wasn't an issue I thought about or considered. It wasn't something on my mind or my radar. It's very much on my mind and my radar today. I've heard from the young people that are sitting behind me. I'm so glad that the young prodigies are here. And by the way, I'll remind you, you got an email with a link to the last time that this bill was before a legislative committee. I encourage you to go back and watch that if you haven't already. And if you haven't watched it at all, go see it. But these young folks were here and have testified. And I'd be remiss, Mr. Chairman, if I didn't also give credit where it certainly is due to Representative Attica Scott, who I believe is also behind me, who was the first person to bring this up. She's filed this in the House a number of times, and she deserves the credit for having done that, and I'm glad she's here with us today. Again, others, just like a lot of things that I and you and other legislators have done, there are a lot of people who carried water on issues long before I came around, and this is one of them. I'm honored to be the sponsor of this in the coming session in the Senate. I hope that there will be a House sponsor to bring the bill forward. It's actually made it out of a committee in the House. But you know the bill. It's my hope that this bill can have passage in 2023 and land on the governor's desk to create protections in our Civil Rights Act and in our schools for children like the children behind me, to protect culturally important things about who they are, including their hair and the hairstyles that they wear. I wish I could have that hair, but that's not ever going to happen. There's nothing fancy I can do with this, what little of it I've got. But I think this is a simple fix that we can do to address. And you've heard them talk about real stories, real things and circumstances and situations that have happened, not just in Kentucky, but around the country, where children with various hairstyles that are culturally important to them have had just terrifying things done to them without mom and dad being there, without any explanation, just because it didn't meet some code or some standard or some expectation. We can fix that, and we should.
And then, good afternoon. I'm Terrence Sullivan. I'm the Executive Director for the Kentucky Commission on Human Rights. And just to speak a little bit more about the Crown Act and why it's important to our agency is the state agency that enforces KRS 344. So it makes sense to have some discussion on what it would do and why it's important. And not even speaking specifically to the impact on children and students, because that's very important, and that's something that I personally care a lot about, and especially the tie-in from having negative consequences at school that eventually can lead to negative consequences within the justice system, because a lot of times the first touch point you have with the justice system starts in school. And so we need to make sure that we keep children out of that system because of the way that their hair grows, because our hair grows differently. And thinking about this commission and the purpose and the access to opportunity, that's another important part that I wanted to discuss just briefly. Just looking at the commission right now, there are two people that I can see that, looking at some of the policies that we get in our office, they would not be able to have a job there. And that's not fair. We had 2 cases just last week where there were policies that were put in specifically to weed out certain populations from the job force, and they would change their policies and the dress code just to make sure that they had a specific look. And that's not right. We want to make sure that we grow the workforce, not take away from it just because of people's natural hairstyle. And since 2016, our office has seen, we talk about data, we've seen an influx of huge growth, actually, of racially based job discrimination. For as long as the numbers were tracked, our highest percentage of cases were brought because of employment disability discrimination. But after 2016, that changed. And so now we have a higher level of race-related discrimination, and a lot of times they do it by using hair as a proxy for race, and that's not okay. And so hair policies have no bearing on the functions or the ability to do a job or the skill that's needed. It's simply a way that they can discriminate. And so that's something I wanted to discuss. Lastly, and this was alluded to earlier, but this also is a health issue. I thought about this last week when I found out I would be talking about this, and I was like, well, it's a health day, Howard. But it is a health issue. The National Institutes of Health just put out a study that the use of relaxers to make your hair straighter has been linked to causing uterine cancer in women. And so I had a conversation a few weeks ago about this bill. And one of the things that was said was, okay, the way that you do your hair is still a choice. And it's not a choice that everyone has to make. So, and it's really dangerous when that choice could also lead to uterine cancer. And so this is one of those things that I think is very important to pass. It's a simple fix, as Senator Westerfield said, and it's something that has to be done.
Gentlemen, thank you. Thanks for the presentation. Co-Chair Heverin, I know you had planned to leave at 4, but wanted to ask one question, so the chair will recognize you first.
Thank you very much. Thank you all for your presentation. I'm sure if you remember from the committee, I was very supportive of this, and I voted in for the bill for Riley Oleka, and which is my honorary niece, which is the daughter of O.J. Oleka. Yes, and now I would support it for his other daughter, Reese, as well. I want them to live a life where this isn't a concern. So thank you all. Go back and watch the committee. You can see my other longer comments, and thanking Representative Scott as well for her work on this. It is very much appreciated, much needed, and unfortunately she will not be here next session, but I hope that we can get that passed and worked on, and she can celebrate with us in that joy. My question is, last year when we were talking about it, there was some concern being brought up about this would be a mandate on businesses. I disagree with that, but I wanted to see if you could maybe take the time to clear that up, just for the record, what your all's thoughts were.
Sure.
You go ahead.
So it's not a mandate on businesses for multiple reasons, but the main reason being we really shouldn't have to tell people not to discriminate because of race. That should be the first point. But as far as businesses are concerned, this is something that in theory can happen now, but it's harder because we don't have the specific statute. Courts and HR executives, actually, human resources departments also like this because we need to clarify some of the issues and how we discuss it and look at it. And so they prefer to have this clarified to say down the line that it's applied equally to everyone. And as far as another conversation that came up was about smaller businesses, and there are already protections for employers and for employees in businesses that are 15 or more people. And that's really where our authority and employment kicks in. And so when this passes, this will be something that if it is brought up to our office for investigation, we'd have to look at the application across the board. If it's something that is consistent with everyone, if there's a rule that is put in place in your policy or whatever your dress code is, if it's something that doesn't isolate one group and it's applied equally to everyone, then it's okay. But it's really just to make sure we're not doing what some of these businesses that have been brought to our attention have done, where they specifically write their policies that would exclude certain people from being able to have a job.
I would echo everything you just said. I don't think it's a burden on companies of any size to not discriminate on the basis of someone's hairstyle. And holding them accountable to that, I think is pretty modest and pretty slight, but immeasurably profound to the human being who's positively impacted by that.
Thank you. I appreciate that. I think sometimes in the General Assembly we just need things on record of why, and answer some questions that get brought up at the very end. So thank you all very much. Thank you for your presentation. I apologize having to leave. I have to get back to the 18th District. And as you all know, it's a long drive. So thank you all very much.
Talk to me about long drives. Yours is literally the halfway point for mine.
You chose to live where you live. Thank you all.
So I'm going to exercise some quick prerogative here as chairman to follow her conversation and questioning to clarify a point that I think I heard you make, because Senator Westerfield and I had this discussion prior to committee, and this was a concern that I raised from a policy standpoint. If under safety regulations in my manufacturing plant, I don't permit anyone to have hair longer than 15 inches,
right,
some amount, for safety reasons, then what I'm hearing you say is that is not a discriminatory statement, that still stands as a safety requirement for anyone that may seek employment with me. Clarify?
So the first point, you said anyone, so that's a good thing. But as long as there's a legitimate safety concern and it's universally applied, you can have whatever safety restriction that you feel is necessary for your business.
Very good. Thank you. Commissioner Drake, the chair recognizes you to be followed by Dr. Olika.
Thank you, and I will be brief. And with all due respect to the chair, I want to say in 2022, I find it, as a Black woman with braids, and underneath these braids is natural hair, insulting that this is the hair that grows out of my head and the heads of the young people that are sitting behind Senator Westerfield has to be legislated.
Agreed.
It's insulting in 2022. Only 19 states have passed the Crown Act, so we still have a long way to go. My daughter has natural hair, my mother, my sister, my aunt. So I tell them all the time, this is not an issue about hair. We know what this issue is about. This is an issue about racism. Everything we've talked about today has been about racism.
Yes, ma'am.
My daughter shaved off all her hair when she was a 9th grader at Ballard High School and was relentlessly bullied to the point where she wanted to commit suicide. Now she has a big afro and helped those young people behind you pass the Crown Act in Louisville as a legislative assistant for Ja'Cory Arthur. So this is an issue that's near and dear to my heart. I really don't have a question, but I would not miss today and sit here and not say something. That in 2022, the work that Representative Scott has tried for years to get passed, that we are still debating if Black people can have the hair that grows out of their head. For Mr. Sullivan to see that 2 people up here wouldn't get a job, and clearly it's me and Dr. Olenka, because of our hair. That is so unfair, and it's not. For me, I'm a commissioner here. I'm appointed to the Kentucky Performance Arts Board. I received a doctorate from Simmons College. I graduated from the University of Colorado with honors. I could go on and on and on as an author of 11 books, and none of it had to do with the hair that grows out of my head. But what growing this hair out of my head did do, and seeing other people that looked like me, it made me see, oh, I could be a Judge Ketanji Brown Jackson that has braids in her hair, or to see former First Lady Michelle Obama with braids in her hair, that I could be that. And everything that we talked about today for Black people and the stress and the weight of being a Black person, this is where it starts. And if we are going to be about the business of race and access, somebody on the House side needs to sponsor this with Senator Westerfield, because this is where it starts for young people to say, it is okay for me to be in this space with my hair, for these young people to see me up here. It is okay. So thank you for this, and thank you, Mr. Sullivan. And thank you, Chair. I know I went on a little bit, but thank you.
Dr. Oleka, to be followed by Commissioner Roberts.
Thank you, Mr. Chair. Just for clarification, it is these specific young people behind you who helped pass the bill in Louisville and are looking to pass the bill in Frankfort?
Yes.
That was just an excuse to give a comment. I feel like I had to ask a question. My children were invoked, so I want to make sure I could speak. Let me just actually speak to you young folks behind them. Thank you for what you're doing. It is incredibly powerful and gives me pride to hear the conversation that we've been having all day about the challenges and difficulties that exist in Kentucky, mainly for Black folks, and to see you young people here getting involved in the policy conversation, in the political discussion, because you simply want to make sure that everybody can value you for the way that God made you, the way that you value yourself. This is incredible what you're doing. And imagine, because you all are young now, not old like we are on this side, but eventually, 5 years, 10 years, 20 years from now, you'll have even more experience, even more credibility for the leadership that you can provide. Imagine what you can do. The very challenges that we're talking about now, you can help solve them. Not the Crown Act only, not the value of who you are as human beings because of your hair. And again, my daughter has very similar hair like what you've got. The little one's 7 months old. She'll have a whole lot of hair yet, but it'll probably look like that too. Imagine what you all can do on the issues of healthcare long term, the issues of housing long term, the issues of job opportunities long term, all because you get this experience right now, seeing success and doing what is right and necessary for your community. Dr. McCants earlier said that it was peers that you all listen to. People should listen to you all. Your peers should listen to you. The adults in your lives, we should listen to you. Thank you for what you're doing to be young and so powerful and so youthful. I just appreciate everything that you all are doing. Thank you, Mr. Chair.
Last question goes to Commissioner Roberts.
Thank you, Mr. Chair. I just had a couple comments. Some folks may know that the U.S. military, specifically the Army, has relaxed their grooming standards.
I did not know
that.
Yeah.
And so in a place where, I don't know about the other branches because I'm not familiar with the Army, but in a place where uniformity, discipline, all those things that you expect from the military, if they can do it,
Right.
we can do it here with what we're trying to do here today. So I just wanted to make that comment. And then I want to follow up on Dr. Oleka's comments to these young folks. I tell you what, first of all, you look great. And at risk of being too cool, I mean, your style, fire, right? Is that the word? Fire. All right, that's all I got. Thank you.
Commissioner Roberts, thank you. Hey, thumbs
They'll
up
film
there.
a TikTok with you right after the hearing.
We have a last question from Representative Brown.
Thank you, Mr. Chairman. Thank you for indulging me. I don't have a question. I've got a comment, and I want to comment the chairs of this committee and staff for putting together today what I think is the essence of what this Commission on Race and Access to Opportunity is about. From the beginning to the very end, Senator Neal left out and he came back because it was so good. He didn't tell me that, but I know he did. But I'd like to congratulate also the young people and the fact a young man held the door for me when I went out a little while ago, and it is very, very important. And you all stayed and you were patient. You didn't fidget. You didn't go through anything. But in 10 to 20 years, you all will be the people that are making the decisions, and this is very, very important for you all to remember. Put a pin in this one. because it's very, very important that you be the leaders in your community and in our state that are about doing the things that are necessary for the improvement and the uplift of our state. All these issues today, hopefully they can get a copy of the agenda and the information that was discussed. Senator Westerfield, thank you for pushing this forward. Mr. Sullivan, thank you. I want to get with you as early as possible to co-sponsor the Crown Act. And in the absence of my dear friend, Representative Atticus Scott, we're gonna make this happen this time. With your help in the Senate and mine in the House, we're gonna make this happen. Thank you all. Thank you, Mr. Chair.
Thank you all. And building on Representative Brown's comments, all of the materials are online, so I encourage, especially the 4 young people in the front that have been so talked about and so appropriately recognized, get your friends to sit through some of this with you. This is all available online, proceedings, everything's been videoed. All the materials are available online. Help build the narrative that we all want to live into. Thanks to everyone's presence. Be aware of the next meeting, and this meeting is adjourned.